Hello, everyone. Welcome. My name is Briar Harvey. This is the Voices of Neurodiversity. And today I'm really excited about this conversation, y'all. I'm here with Breck Rice. We met on Lunch Club, which I have talked about before. And we just had a really lovely conversation, and I really wanted to get him here for all of you. So, first, Breck, tell us about yourself.
Yeah, well, thanks for having me. First off, Blair, it was a pleasure meeting you and getting to know more about your mission and a lot of parallels here. So I've been in healthcare now for over 20 years. Got started back in 2003 when I was recruited to go to work for a technology slash health organization back in Memphis, Tennessee. Was the grandfather of the industry back in those days of doing electronic billing, claims processing for community pharmacies. And so that's where I got my introduction to healthcare and helping community pharmacies better help the patients they were serving. And had a great career there. Came in pretty early on in the company, so they were growing rapidly, and we eventually had the majority of all the pharmacies in the entire country using that platform specifically for their workers' compensation claims processing. And so a big pharmacy benefit manager, big PBM, saw the opportunity to acquire that company and funnel all of that claims data into their company and make millions and millions of dollars. And so that's eventually what happened to that company that all these community pharmacies loved and trusted and counted on for fair reimbursements. And so that left a hole in the marketplace where there was no longer a true third-party payer that was looking out for the best interests of community pharmacy. And so I got to help co-found a new third-party program, which we call ServeRx, and continue that mission of helping community pharmacies, a lot of our independent, small regional chains, and a few of the bigger chains as well that use our platform to better serve patients and help those injured workers get the medications in a timely manner. During COVID, though, there was a lot of companies that weren't didn't have the doors open, didn't have employees in. And so some of our independents were really struggling to stay alive. And we had to tighten our belt as well as an organization. And so I started looking at other services that we could introduce to community pharmacies to help them. And that's what got me looking at some wellness platforms and bringing in clinical services into community pharmacies. And with that mission and purpose, I've been asked to serve on a board of a new health and wellness organization called the Fountain of Youth. You can't trademark the Fountain of Youth, so they just call it FOY, the acronym FOY, F-O-Y. FOY Therapy is bringing clinical services, wellness services into community pharmacies. And even though these pharmacies are the head, the location of the clinic, it's not the traditional, let's go to the pharmacy to get a prescription to mask a symptom. That's exactly the opposite of what we're trying to do. We're actually trying to get to the root cause of disease states and sickness and aches and pains, and not just treat smoke anymore, but get to the fire. And so that's a lot of the focus is on preventative wellness, analyzing, labs, looking at blood markers, identifiers to tell us what, that patient may eventually have later on down the road, analyzing nutrition levels. We have a way of getting a score of some of these antioxidant levels to see how low they might be and what we can do to improve on those. There's new technology that was just approved by the FDA that increases circulation, reduces inflammation. Interesting thing about inflammation. Out of the 45,000 disease states that we know of, over 90%, it's actually 93% of those diseases originate from inflammation. So if you can reduce inflammation, have higher antioxidant levels, less free radicals, you're going to prevent a lot of diseases.
Well, and there's a difference between preventative care and curing disease, right?
Yeah, yeah. What is that? The old saying, an ounce of prevention, is worth more than a pound of cure. So
Mhm.
that's kind of the focus now. And I consider myself a disruptor in healthcare because that's not the popular thing to do if you're in pharma, right? Big pharma makes billions and billions of dollars, and trained the general population very well to have the mindset of, oh, if you have something that's ailing you, just take a pill for that. They make something for it. You just pop a pill, and you'll. It's not alleviating anything. It's not making anything go away. It's just masking the symptom, or not allowing your body to feel that ache or pain.
And that's how we end up with our modern day narcotics crisis.
Yep. Yeah, absolutely. And you start looking at what some of the side effects of these synthetic drugs are, and you can obviously see it in our elderly patients that we're doing more damage than we're doing good. I think the U.S. or Western medicine has some amazing things to offer. We're really good at acute care. If you have a broken arm, there's no one better than an orthopedic person to put that back in place and make sure it's all lined up correctly. I mean, that is perfect thing. If you have an infection, there's no better thing to do than to get rid of that infection than to get on an antibiotic. And so we're really good at acute care. But for chronic care, long-term care, we're doing more damage than good with Western medicine.
Because we're not seeking to prevent, we're only looking to medicate to maintain. I think a really good example of that right now is the Ritalin and stimulant shortages for ADHD, right?
Yeah, yeah, yeah. There's, we've been hearing a lot about that. We have a lot of compounding pharmacies in our network, and so we've even reached out to them to see if there's a way of, uh, replacing the supply chain with actually manufacturing or making it in house, and it's a very difficult process.
Not just because of the stimulant nature of it, but because of the regulation that prevents. I mean, Adderall has been around for quite a few years at this
Mm-hmm.
point in time.
Yep.
So producing it shouldn't be a problem.
Right. Yeah, you're absolutely correct. And it's interesting too, if you look at a lot of medications, and if you look at the pedigree where they started and what they have become, um, and you find that a medication or a drug developed, the science behind it was developed for a specific purpose, but then they find out through, clinical trials that it's also benefiting another area. And so you quickly see them shift their whole focus in marketing to capture the largest group of patient population. So you see medications that were, in pain management, that were intended for end of life care, to make somebody just feel comfortable for their last days, mainly in oncology, right? And now those are being brought right into mainstream. Oh, you have a work related injury, let's give you this narcotic that was originally developed for helping somebody feel comfortable when they pass this life.
I remember when I was first diagnosed, it was in the 90s, and there were so many pills available to me. They just basically threw them at me, which I think increased my own personal tolerance, But I also suspect that some of the problems that I have were drug related. And there's no real tracking or awareness of any of this, is there?
Yeah, and it is pretty interesting, right? We talked about this last time we met. Is that the first two or three medications really have a purpose, right? They're intended to help alleviate some symptom. But by the fourth, fifth, sixth medication, those medications now are counteracting the negative side effects of the first two medications, and then it just daisy chains from there. I work with a lot of clinical pharmacists who are now focusing on deprescribing, identifying which medications are doing more harm than good, and taking those medications away from that patient. We had one patient that I'm aware of that was on 28 different medications, and they were able to eliminate 20 of those, but still, the medical providers that they were working with, really had a strong case for keeping those last 8 medications for this particular patient. But to eliminate 20 meds, that's incredible if you think about that. And they were all, counteracting some other side effect of one of the first prescribed medications.
Well, part of this is the benefit of having a relationship with a pharmacist, which I don't think many people actually do nowadays. But what is a functional pharmacist patient relationship supposed to be like?
Yeah, and that's one of the missions, right, of FOI, is to bring that clinical setting right into the pharmacy, so you have that interaction. And more pharmacies are focusing on the what's considered MTM, so a medication treatment management, and actually having these consults with patients. But you have to schedule those, right? Because when you're at the counter and you get the new prescription, and they always ask, do you have any questions for the pharmacist? And 99.99999% of the time, that person is in a hurry, and they just, no, I 2 a day, one before breakfast, one at dinner, they're out the door, and they're not going to really sit down and be consulted. And so that's why I think pharmacogenomics is so important right now, to be able to
Tell
actually.
us, for the people who don't know, what pharmacogenomics is.
Yeah, so it's basically a DNA test, right? It's identifying the individual patient's their genetic makeup and how they metabolize certain medications. And the reports are so easy to interpret. You have it's a stoplight approach. You've got the medications that are in the green category. These are ones that work with that individual patient's genetic makeup. You've got the ones that are in yellow, proceed with caution. And then you have the medications in red. These might kill you, is basically, how that's broken down. Now, medications also have, the drug interactions too. And so that you have to be very aware of that. If you're on a green medication, doesn't necessarily mean that every other medication that's green is okay, because those two medications could counteract each other or have a drug-drug interaction.
Pharmacogenomics is something I have educated medical practitioners about, and they did not even know that it existed. So, where is the disconnect between knowing what works for me and my body and having that be a standard practice of care?
Yeah, I think we can point fingers a lot at big pharma, that they're in there to make as much money as they possibly can, and they have really developed some amazing life-saving drugs, but they do have shareholders to account to, and they're trying to turn as big of a profit. They're for profit. And so sometimes we lose our way in actually focusing on the patient care. aspect of it. Then, if you look at the medical practice side of things, you've got people going through med school who they only spend a certain portion of time. I think it's like 1-2 semesters on pharmacogenomics, on the pharmacy side. And then you've got these PharmDs who have, doctorates in pharmacogenomics. They understand the drug interactions. They understand the chemistry behind the medication that was developed. So there's a big disconnect between the provider who is prescribing, and sometimes those prescribing habits are based off of what a drug rep is feeding them in their ear. Hey, this is going to, do so much for your patients. You're going to solve this problem, this problem, this problem. This is a miracle drug. And they're writing a prescription based on that little bird in their ear, not really fully understanding what some of the interactions may be, where the PharmD has that higher level of knowledge on the pharmacogenomic side. Now, again, I wouldn't go to my PharmD to set my bone or do some things that I need the provider to do.
But your pharmacist is still a doctor. They went to medical school. They have this entire comprehensive medical training with the additional component of the chemistry that makes all of this interact with the body.
Right. Yeah. And that's why I think it's such a beautiful marriage to bring clinical services right into the community pharmacy. You think about, the olden days when they'd have to ride the horse into town to go get the doctor, and he'd come out and come riding out to the farm to see the patient, and he brought the pharmacy with it. He had his little black bag that he brought out with him, and kind of brought the pharmacy with him. And so we're looking at going back to those simpler times where you can just go to one place, one location. You don't have to go to an urgent care provider or wait around for months to get in to see your PCP, your primary care provider. That you can go to one place, your community pharmacy, and have some clinical services done and be right there if a medication is needed.
Because again, we're focusing on holistic care. So what does that look like for someone who has no concept of preventative treatment?
Yeah, so a lot of it is education, right? And you can find clinical studies that have been done on proper nutrition that have reversed illnesses by having proper nutrition. A 50-year-old study on diabetic blindness that can be reversed with proper diet. You're not going to hear very much about it because it's not real profitable for big pharma to tell patients eat better, right? Have a healthier diet.
That's correct.
Yeah. So statins are a big moneymaker. Things that are controlling cholesterol. And, very few people know that there's certain natural things that can lower your LDL, your bad cholesterol, better than even the highest performing drug. Simply a handful of Brazil nuts will lower your LDL by 20%.
But that brings up another issue, because there's a Brazil nut shortage, and particularly in the United States, food is not always at a level of quality that is actually going to make a difference.
Yeah, and you can look at regions of the world too that have been overusing the soil, right? And they're depleting nutrients from the soil, and so they'll be missing, certain elements in their blood work that can allow disease to creep in. And so there's some really interesting studies that's being done on that. It's so important, the science behind growing crops, of rotating the crops, and and making sure that you're using organic matter to replenish the nutrients in the soil rather than chemicals that are basically burning out the soil. It's a science all in its own, but we certainly don't have the same nutrition level, even if you're eating, the greens and all of the fruits and vegetables and nuts and seeds that you should be consuming. You're not getting the same level of nutrition out of those that maybe our ancestors did when they were out there growing it themselves. The other thing too is in food science, it's a lot of produce is sold by the pound, and so you need bulk, right, in order to maximize your profit. And so you'll see citrus oranges that'll have really thick skins. Well, that's on purpose because there's a lot of weight in there. Or you'll see blueberries that are the size of grapes. Well, they've been genetically modified. So many different things that have genetically been modified to produce weight or bulk rather than nutrition.
So, if food is the cure and the food is bad, what do we do, sir?
You just have to eat more of the good food, right? Knowing that maybe it's not as the same nutrition level, but we just have to consume more of it. And that's not our typical Western diet, right? We eat a lot of processed things. And so to try to get back to eating more fruits and vegetables and understanding that's kind of the purpose behind one of the technologies that we're bringing into these clinics is doing, I call it, a bioscan. It's basically checking the antioxidant levels of patients. And so that gives them a base score. And then you put them on a program to improve that score, to consume more antioxidants. That can also be, ideas like, in your breakfast oatmeal, you just need to add a quarter teaspoon of cinnamon. You get more antioxidants out of a quarter teaspoon of cinnamon than most anything else of that same bulk. But there are supplements that also can be added to diet in order to improve that score as well. So it's kind of a test therapy test. So you're getting a baseline, putting a patient on a therapy, then you're retesting to make sure that they're improving.
So, how do we consciously incorporate these things into our life and our diet?
Yeah, people only respect what you inspect, and so there's got to be something that's measured, and that's why these analytics is so important, to sit down and actually measure them with the patient, and then have them return and report. They come back in 6 to 8 weeks. You retest again to see what improvements have been made, and if there aren't any, you're recommitting that patient. But you now have the evidence behind the theory that if you don't make these corrections, this is what's going to happen down the road. And the easiest example of that is diabetes, right? You keep consuming processed food, you keep consuming things that are high in sugar content. I mean, just go to your local grocery store and just look at the grams of sugar on things you wouldn't even think, oh, I'm getting wheat bread. This has got to be healthy. Turn it over and look at the levels of sugar that are in bread.
American bread, though, is classified as a dessert in most of Europe because of the sugar content found in it.
Yeah. I love fruit and yogurt parfaits, and that's kind of my thing with some a healthy granola or something like that on it. And I moved away from the the traditional, Dan and whatever, because of all the sugar content, and moved to, to a more Greek, no sugar added, and let the sweetness of the blueberries and the strawberries and stuff come out and sweeten that. And now if I go back and have a regular yogurt, it's nasty to me how sweet it is. It's just absolutely like I have to mix it with Greek yogurt or something because it's just too sweet.
Because it's too sweet.
Yeah.
Once you start removing, and I have a problem with sugar. Sugar is my own personal nemesis, and it's rough. It'll sneak in everything. It's in salad dressings. It's
Yeah.
in bread. Although I don't eat that anyway. Although it's still in gluten-free bread. You'd think
Yeah.
we've removed the wheat. We would also remove some of the sugar, but in fact we do not.
No. Anything that's processed, the manufacturers know in order to get consumers to like the product and buy it over and over again, they've got to put something in it that that stimulates our brain to say, "Oh, that's delicious. I got to have more of that." And sugar happens to be that refined sugar. It happens to be that ingredient that seems to be working.
So, what can people do to integrate more prevention into their lives?
Yeah, I think again it goes back to the education, right? Understanding why, or why not if they don't, and that kind of brings me to a little social media campaign I launched at the end of last year that's surprisingly blown up and started to get quite a bit of followership. And it's information that's available to everyone. When you go pick up your prescription, you go get a commonly prescribed medication, and it comes with the whole list of information that goes along with that medication. Not only how to use it, when to use it, how many times a day, all of that, the quantity and all that, but it has all of the things to be aware of that could have negative side effects that you should look out for. But how many people actually look through that material? They take the bottle out of the bag and they throw all the paper away and start taking the prescription. And so I launched a campaign called Scary Drug Facts, where I simply list off the common side effects of prescribed medications. And I started kind of on the pain management side, and my post on tramadol has like close to 3 million views. There's so many people that had questions about one of those side effects, or how long they've been on it, and what are the short-term use versus long-term use, and so that really kind of went viral and blew up. And so now there's over 100,000 patients that are now following these posts that I put out. I try to do it daily, but sometimes I get busy, so I get them out as often as I can.
And we've discussed this. The issue isn't the drug in and of itself. In many cases, the drug is important, it's valuable, it does save lives. The issue is the overprescribing of the drugs.
Overprescribing and the dependency of it. So most medications, unless, like I said before, if you're in pain management, unless you're a terminal patient that is just trying to make them comfortable through their end of life, most medications are developed for acute care. But we so often put people on them for a injury, and then they become dependent on it, and now every little ache and pain they need another one. Or you put somebody to help them with a mood adjustment, and they become a dependent on that and want to have that almost like a security blanket. And there's some really fascinating research that is coming out on different herbs and different spices that we don't normally add to our diet because, they're things that seem to come from, maybe Asia or someplace. Well, other parts of the world have been using different, different food enhancement, flavoring with spices and things like that, that have so many health benefits that we're not even aware of here in Western.
Turns out monosodium glutamate is good for you.
Really?
I read some research on this one fairly recently that because of its umami characteristics, it's actually really great for people who need to reduce sodium intake. So if you replace table salt with MSG, it reduces your overall sodium consumption, which is incredibly beneficial to certain illnesses and types of people who struggle with sodium consumption. But we demonize it automatically in so many instances. The the alternative there, though, is I know people who have been on antidepressants for decades.
Mm-hmm.
And that's not how an antidepressant is supposed to work.
Yeah, and that leads me back to the research that's being done right now. There's over 500 researchers working um, on herbs and their benefit to mental health, and focusing on depression, anxiety, mood therapies. That the evidence behind it, using it, going a natural approach, it's amazing what the science is saying. We're told follow the science. Well, what the science is actually showing through these studies and through these over 500 researchers, and they've narrowed it down to some pretty specific herbs that we should be focusing on. And you think about that, it's natural, right? So it's not going to be chemically based. It's not going to have anything in there that's going to have all these side effects. But even natural remedies or products can obtain too much of something that you shouldn't, you could take to a certain level, right? But then you shouldn't eat Brazil nuts, for instance. To get that efficacy of dropping your LDL by 20% is literally 4 or 5 nuts a month is all. If you consume, handfuls a day, you'd be taking in too much of, something else that could be, harmful to your diet.
And the research I read recently about serotonin, and that we are now unsure of its effects in chronic and chemical depression. So if serotonin isn't what's causing depression, then all of those SSRIs, selective serotonin reuptake inhibitors, are probably not the drugs that people should be taking.
Correct. Yeah. Yeah. It's, if you look back at, again, Western medicine is saving lives. There's no question there. But if you look back at, if you follow the money in where big pharma came from, it traces all the way back to big oil. And you've got the Rockefellers who controlled a lot of the finances of the early, Americas, and big oil, and as byproducts were experimented with to say, okay, what can we do with some of these byproducts? That's where chemicals come from, and that's really where the birth of big pharma came from. And so, if you think about it from those standpoints of putting petroleum-based chemicals into your body, you would think that would wake a few people up and say, hey, maybe I ought to look at going a different route here. And one of my sayings is that medications have a purpose, but when the side effects outweigh the benefits, that's when you need to do something different. And if you look at the lists, and these are listed clearly on the manufacturer's website. You can go to some other really great resources that I use all the time, our WebMD and the Mayo Clinic. I mean, I love the Mayo Clinic because the way they lay out where the drug interactions could be that you need to be aware of. Then it shows what the common side effects are. It shows what the rare side effects are. And then it can show, it basically says undetermined, meaning that some patients experience that, but they don't know if it's directly related to that medication. It could be something else going on in their, in their genetic makeup, but there's a lot of, undetermined reasons why. But when those side effects start to pile up and outweigh the benefits that you're actually getting from the medication, that's really when people need to reflect and say, hey, I need to do something different. I'll give you a personal example.
Okay.
Love spicy foods. Always have. I've always loved spicy food, and it was almost a challenge. Get it, the spicier the better. Well, unfortunately, I started to get older, and I started to get the heartburn and everything.
I have also experienced this trauma and loss. Yes.
So I had like a chronic sore throat, and I didn't know what the issue was, and go to the doctor, and I thought it was just drainage from allergies. He's like, no, you've got acid reflux. Your stomach acids are actually burning your esophagus. And so we need to do something about that. So they put me on omeprazole, wonder drug. Oh my goodness. I could take just one of those a day and continue to not change my diet or do anything different and continue to eat my spicy foods. And man, that was a perfect solution for me for a few years. And then I went in after being on the medication for about, I guess, 3 years. I went in to get it refilled and met with a different primary care doctor because now moved to, different area. And finally, somebody explained to me, who I've been working with pharmacists for 20 years, explained to me, that this medication is robbing bone density, right? I'm like, oh no, I didn't know that. Yeah, so it was taking bone density away, and I was like, well, that's something I should pay attention to. That very winter, we were up skiing and snowboarding in Vail, Colorado, and I was coming through the trees and hit some steep Mobley area, and just hit a bump just right and completely blew out my ankle. I mean, completely blew it out, where the tibia broke in two and one piece of it slammed into my malleolus, the little ball on your ankle, knocking the malleolus completely off. So now I've got a screw and a washer to put that back in place. I've got a plate to put my bone back in place, all because of bone density. Nutrients being robbed out of my bones. So, hey, then I had to wake up and say, okay, I need to start looking at a different alternative here. And I, like most medications, once your body is used to that, it is really hard to eliminate that from your diet. The acid reflux, the heartburn came back with a vengeance.
Oh, I'm sure it was worse the second time around.
Absolutely was horrid. And trying to change your diet, it didn't matter. Even staying away from acidic foods, my stomach acid was just trying to re-regulate, and it was a horrible, horrible experience. So the sooner that patients realize, hey, this is doing more damage than good, and moving away, the easier to get off of or not have those withdrawal symptoms that come with a lot of medications.
And the issue here really is that so many patients don't have a kind of relationship with their primary care physician. Listen, if you're Canadian, your odds of even having a primary care physician right now are like 1 in 8 or something. It's absolutely ridiculous. So how am I supposed to know any of this stuff?
Yeah, it's that's why we launched little educational campaigns like Scary Drug Facts. It's to get people to start asking questions. get people to sit down with their pharmacist for a consult. And it doesn't have to be in person. They can do those consults right over the phone, and we can do them virtually. We're doing a lot more virtual care. There's actually a study out that shows that virtual primary care will surpass in-person primary care very shortly. And that, the one thing that we have to thank COVID and the pandemic for is telehealth wasn't really catching on. There were a lot of telehealth companies out there, but they really didn't have the masses going to them to utilize them until the pandemic. And now it's more natural, right, to actually have a visit through through a computer screen like this rather than be there in person. And I would argue that you actually might even get more time with that provider than going into the office, because you have a scheduled slot of time that you're meeting with that concierge doctor or primary care provider. You're not meeting with their PA or their nurse that's doing the vitals and all of that. It's usually the doctor.
One of the things that we like to talk about here on this show is particularly how this affects all of us. And you say concierge doctor, and I go, well, that's expensive. What are we doing to get better care to people who cannot afford it?
Yeah, so one of the interesting focuses with the FOI therapy or the Fountain of Youth is that if you look at the expenditures or the weight on the healthcare system for cost, it's actually about 30% less to come to a clinical setting at your community pharmacy, to do a telehealth visit, to do remote patient monitoring. Works out to be about 30% less of a cost if someone was having to pay for it out of pocket, or it's less of a financial burden to the healthcare system than going to, an urgent care or a walk-in clinic. It's probably 200 or 300% more cost effective than going into an emergency room too, as well.
Absolutely.
But what's interesting is some of the technologies that we're bringing in, we're making sure that it goes through the whole Medicare, Medicaid process, so that those insurances can kick in, and we're doing that with a lot of the elderly patients, right? Because making sure that, like the pharmacogenomics, for instance, is used to be a fairly expensive test, still expensive, but it's come down quite a bit. But now to get the payers to actually pay for those tests.
Correct.
Yeah.
That is often a problem.
Yeah.
Because insurance doesn't like preventative care.
You would think that they would love it, right? That they're not going to have people with obesity and diabetes and blood pressure issues and heart problems down the road. And that's why you see more and more companies putting in programs that are self-care type programs. If you join a gym membership, you can get reimbursed for that gym membership with a lot of insurance now. But where's the accountability? You could have the gym membership. Are you actually using it? And so, doing remote patient monitoring, actually, checking in with patients and seeing what progress they're making, I think is going to have some real huge benefits. We have a technology partner who is developing the gamification of patients doing what they need to be doing. And think about it. If you're a big warehouse, like an Amazon setting or something like that, and you have all these people on the floor that are having to go pick the parcels or the products and get them ready for shipping and everything, and it's a lot of physical activity. Well, if they're not prepared that day for that physical activity, they're going to either be less productive or they're going to have an injury. And so a lot of the warehouse workers have a higher level of work-related injuries. Well, what if there was some kind of a mechanism to make sure that they were physically ready for that shift? And they would get points for that. And those points could be turned in, for a set of AirPods or something like that. Well, I'll tell you, a $250 set of headphones is a lot less expensive for that employer than covering.
Than workers' comp? Yes, it is.
Exactly.
And the issue continues to be, how do we integrate these systems in now? We're aware that these things aren't working. We're aware that warehouse workers are going to get stress-related injuries because it's a stress fracture type job. But we're not changing things institutionally. So, how do people help bring about this change?
Yeah, we look at things as being, status quo. It's you have people in positions that are making decisions not necessarily in the best interest of the organization, but in their own best interest, and so that's where you get into the status quo. And oh yeah, let's just keep doing what we've always done. Well, we know that that's also the definition of insanity. Doing what you've always done and expect a different outcome. And so you somehow have to educate, and usually it's with showing the loss costs, and what the overall cost savings can be for an organization to adopt some of these healthier approaches. And that's usually the only way you can get through to it. And again, it's not one individual. It would be great if there was a Mr. Corporate America that you could just go sit down with. No, there's layers and layers, right? So there's the department over risk management, and then a whole separate department that's over benefits, and then a whole separate department over finance. It's getting them all of those stakeholders in a room together and explaining, this is why you need to make this change, because this is what the cost benefit or the savings is going to be to your organization. So there are a lot of companies that are focusing on that. We happen to focus on that on the cost containment side of pharmacy, specific to work-related injuries. So we have a program that helps self-insured employers save about 30% off their pharmacy costs by just going a different route that isn't the status quo. And sometimes you've got the good old boy networks where their buddies sold them the pharmacy benefit program, the PBM program that they're with, and they're loyal to that buddy and not realizing that buddy's company is putting about $100 in their own pocket every transaction. Well, what if you took that middleman out and dealt directly with with folks who could manage that for you and not have that big spread pricing going into to make $1 billion organization on the backs of self-insured employer groups.
And it's a complicated question, but I do think that certainly there are more solutions to be looked at when we cut out the middlemen.
Yeah. There's in workers' comp, we estimate that that's not exaggeration, that it's about $100 going to the organization that's just processing the claim. They don't even own the medication. They don't have the overhead of the pharmacy. They don't have the staffing, all of that. They're simply the processor, and they're putting, more money in their own pocket than the pharmacy who owns the medication, who's consulting with the patient and dispensing that med to the patient. They get about $4 or $5 reimbursement. Sometimes it doesn't even cover their acquisition cost of the drug, but the big PBM is putting $100 in their own pocket. That's why you have big pharmacy chains that have 10,000 locations, selling anything and everything, but yet their PBM that they own actually accounts for 80% of their total profit for the entire organization. It's not from the pharmacy side. It's not
Holy
from all the
cow.
retail. You have 10,000 retail locations, but 80% of the revenue comes from that PBM, that pharmacy benefit manager, who's working off of spread pricing. You've got a big employee health benefits company, one of the largest in the world, that has 65 million lives that are paying their premiums into this health company, for benefits, health benefits. The companies are
Is it
paying.
the one with the duck?
No, this one. What is theirs? I don't even know if they have a logo. It's a big company that owns their own PBM, and 75% of their profit margin comes from the PBM side, not from all of the revenue coming in from premiums of 65 million people.
And I know that other countries negotiate with pharmaceutical companies and get prescriptions at a lower rate. But why have we gone the opposite direction here?
It is super complicated, right? Because where was the medication developed? Where did all the research happen? 90% of development is by U.S. companies, and so they're recouping all that cost of the research, the development. So by the time that medication is now gone through that whole process, it's been approved, by the FDA. It's out in the general population and it runs its course for branded medication. Now it can be redistributed or remanufactured as a generic drug. So most of the nationalized health systems that you hear about, where drug costs are so much lower, is after that medication has gone to, off of brand, and so
Got
it's
it.
much less expensive. So in workers' compensation, in our industry, 90% of the prescribed medications are generic medications. So that's a big cost savings by using the generic med versus the brand medication. And so it gives you some idea of what a huge delta there is between the branded price and the generic price. So unfortunately, it's great that we're involved in the research and development here in the U.S., but with that comes a price. We do pay the higher prices for the manufacturer to recoup all of that upfront investment into the research and development, where other countries, that are on national, programs, aren't contributing to that research and development in most cases.
Right. And I'm not sure how it fits into the ecosystem, but I'm familiar with Mark Cuban's drug program and what he's doing to get low-cost drugs into people's hands. But part of the issue there is awareness. People actually have to know that these programs exist, right?
Yeah, and in his case, he owns a generic manufacturing company, and so this is after the drug has gone off of brand, and they can now buy the rights to reproduce it, and now it's a generic. He was getting beat up from the pharmacy benefit managers, taking their spread pricing and wanting him to take a lower cost of medication so they could improve their spreads, and that's the game that they played. So he got so frustrated with that he started his own pharmacy benefit management company, his own PBM, that they call where they say, okay, it's full disclosure. You can know exactly what the costs are, and so it's a transparent PBM showing where all of the costs are associated. Where your traditional PBM, your pharmacy benefit managers, the big ones like Optum, Express Scripts, and CVS Caremark, those are the three big PBMs that control 80% of the lives of U.S. citizens. So just those three, 80%, going through one of those three, they work off of this spread, between what the wholesale cost is of the medication, on what the payer is going to pay for the medication. And in the workers' comp side, there is usually an established fee schedule. The state of jurisdiction where the injury happened, they have a state industrial commission that comes together and say, okay, this is a fair reimbursement that this medication should be reimbursed at. Well, the big PBMs may give employer groups a discount. They'll say, okay, we'll give you a discount off of what that fee schedule is. So we're not going to charge you that full percent, but on average, it's only like a 5% discount that they're giving the employer groups or the insurance companies in those states of jurisdiction.
So there's a whole lot of money being made here off of.
Right, but they're asking the pharmacy who owns the medication, who's dispensing it, to take a 65% discount. And so, that 5% that they promise back to the payer, they've still got 60%, spread in there to make on each transaction. Yeah, it's a racket. It's the closest thing to organized crime.
Right. I was just about to say that. I am Italian. I know what organized crime looks like. This looks like organized crime to me.
Yeah. And, they spend millions and millions of dollars on policymakers, on legislation, on lobbyists saying this should be a certain.
You can look up your Congress people and know who they take donations from, and I wonder how many of them have PBM donations.
Yeah,
a lot of them.
Yeah, I'm in Arizona, and we fought a battle here for many years in our own home state to make it possible for physicians who are treating work-related injury patients the ability to go ahead and okay, we're going to treat you here, and then we'll have a small formulary of medications that are commonly prescribed for whatever that specialty. You can go ahead and get your pharmacy stuff here too as well. So there was point of care dispensing, which was something that has been from the beginning of time. Remember my analogy of the doctor riding his buggy out to the farm to help, little Mary Ellen Olson or whatever, the Little House on the Prairie, that whole thing, brought his pharmacy with him. Well, from the beginning of time, that's been a right of a physician to also be able to dispense a medication. And the PBMs wanted to outlaw that, because it was bypassing going through one of their pharmacies where they were going to get their cut.
Correct.
And so they legislated for years, and we fought them for years, saying, hey, no, that this should be the right of, think out what this is doing for patient care. We had a big provider down in Tucson who was an anesthesiology pain practice, right? One of the largest in the state. So patients were going there that had severe injuries where they were having to basically get a spine block to block that pain. Well, the last place they want to go after that procedure is to go wait at the pharmacy for 2 hours to get their prescription filled. And so he was just dispensing what would be needed until the next time they could come in or were eligible. So the payers were eligible to allow them to come back in for another spine block. It was a convenience, and it was also, if you think about it, compliance. The compliance goes way up, because let's think about the guy now that gets a procedure, goes now, thinks he's got to go wait around for 2 hours, or they say, okay, you got to come back at 4 o'clock. He's like, I got to go lay down. And so he doesn't go and pick up his medication. So now what is he going to do? Now he's, the procedure pain is really kicking in or wore off. What do I do? And so that's where you get patients that start looking at alternative measures. Oh, let's use something that maybe wasn't prescribed to me.
Right.
So your compliance goes way up when it's dispensed at point of care. But their argument was, there's no controls here in place, and it all came down to the dollars. It had nothing to do with patient care. It came down to that $80 to $100 transaction fee that they were putting in their pocket. They were missing out on that, and they needed that to return to their shareholders and say, hey, we're we're super profitable. We make $163 billion a year, and that's not enough. We got to get more. So let's outlaw that, in this particular state and every state that they possibly can. Probably the next one that's being considered legislation for that right now is Florida, because they're missing out on millions and millions of dollars, those PBMs, by physicians doing point of care dispensing in Florida.
And it's important that healthcare, as such a large industry, affects politics on both sides of the aisle. Everyone has their fingers in this particular pot. Yeah.
Yeah. And not everyone is as educated as you are, there are places you can go to see who the donors are. So I would like to incorporate a NASCAR approach to our politicians. They should wear a jersey that shows who all their sponsors are. That way it's right there in the open. You don't have to go searching.
I'll vote for that. That's amazing. Okay.
This politician brought to you by Pfizer.
I would prefer to know that. I would.
Yeah.
And I think that the more that we're aware of how inherently political healthcare is, the more we're willing to stand up for our rights.
Yeah, absolutely. Yeah, very well said.
Okay. Any final thoughts for us today?
No, this has been fun to visit with you again, Blair. And if anyone has any specific questions or listening to your podcast and want to reach out to me, please do. I'm the only Breck Rice on LinkedIn, so that's a really easy way to find me. That's one of the benefits of having a unique name, is that I'm pretty easy to find.
Indeed. Well, Breck, thank you so much for being here. Y'all, thanks for watching, and we will see you again in 2 weeks. This has been the Voices of Neurodiversity here on the Neurodiversity Media Network. And if you're not a subscriber, you can hop on over to neurodiversitymedianetwork.com and join us there. It's free to subscribe. Paid members get access to our masterclass series, where we'll take everything that we've learned here today, write it all down, give you some resources and some reading notes so that you'll have more to come back to and dig into this topic in greater detail. Thanks so much, y'all, and we will see you again next time. Have a great one.